This video will cover the abrupt lesions, which include traumatic injury to the brain or spinal cord, as well as stroke, of which we have two types, ischemic and hemorrhagic. So kind of four things together, but what they all have in common is that they very quickly impact neurological function. So here we can see some blood vessels that show varying degrees of deposits within them. Some of them are quite narrowed, as you can see here, and this is clearly going to be a problem. The brain requires a constant supply of blood in order to maintain its activity, and if neurons are deprived of blood for a couple of minutes, they start dying. So stroke is going to be a big concern for us, especially as we get into the older years. Now, traumatic injury, whether it be to the brain or the spinal cord, this is caused by some physical force, either penetrating or not, that either shakes around or lacerates nervous tissue. That would be our primary injury. Then, of course, there's the response to that injury, and this isn't always a good thing. Of course, we do have to clean up the mess, but pronounced inflammation can lead to an increase in intracranial pressure, for example, and that can further damage the brain. That would be what we call a secondary injury. So the primary is the accident itself, and then the aftermath that damages the nervous system is secondary injuries. Now, traumatic brain injuries are more common today than they used to be. We can see here a pretty clear plot showing, we'll just follow the purple line. This is just the total events that happen following TBIs, whether it be a visit to the emergency room down here, hospitalization, or death. Now, it looks like death is really, really common, but notice that's over here on this y-axis, so not the most common outcome, despite what it might look like. What we should also notice here is that there are kind of two different trends going on. So even though we're seeing more TBIs over time, we're seeing fewer deaths. And these trends are continuing. So the 2013 estimate was a little under 900 per 100,000 each year. Now it's crested that, maybe in the ballpark of 930 or so. Now, the reason for this drop in deaths, despite the increase in TBIs, is that we've learned how to manage TBIs better. So rather than giving high doses of steroids, which it turns out increases mortality rates in TBIs, we're now managing intracranial pressure without them. And that's helped save a few lives, as you can see. Now, as far as who gets a TBI, there's a relationship with age for sure. As far as, visits to the emergency room, here we can see this kind of U-shaped distribution here. So again, the non-deaths, so emergency room visits and hospitalization, those are over here on the left. So they each have kind of a bluish color to them. And deaths, which are red, are over here on the right. So as far as just having to go to the emergency room, it's a lot more common in the very young. Well, let me get this out of the way. So now we can see our ages broken apart into 0 to 4, and then we go every decade for the next bins. Okay, so the very young, and then we'll get this out of the way, the very old. Now, hospitalization, as you can see here, pretty much stays level until we get older. Then it kind of ticks up. 75 plus showing the highest rate of hospitalization, and also deaths. So death is a lot more common in old age. That's not a surprise. This is true whether you have a TBI or not. Older folks are more likely to die. And we can see the red bars increasing over time. So either very young or very old, those are kind of risk factors for either hospital visits, staying in the hospital, or dying as a result. Anyone who plays contact sports, particularly those that involve taking blows to the head, are at risk of traumatic brain injuries. Military personnel also are at increased risk of TBIs, especially if they're in war zones or anywhere where there are potential for explosions to happen near them. And then male sex is another risk factor. We see about a 20% increase in the risk of a TBI if you're male versus female. Now, those deaths are obviously the worst outcome of a TBI, and the cause of death varies across age. All right, so over here in the very young, again, we got two different axes here. So the blue colored ones, which would be assault, motor vehicle accidents, and self-inflicted TBIs, are on the left. Falls had to be put on their own axis, as you can see here, and they're colored red accordingly. All right, so in the very young, the most common cause of death from a TBI is assault, and that would mean child abuse. Motor vehicle accidents still contribute. As we get older, motor vehicle accidents are the more common cause. I'm not showing young adults here, but the trend follows. So once we exit that kind of delicate young age, assault is a lot less likely to cause fatal TBIs. Once we get into older adulthood, motor vehicle accidents still contribute quite a bit, but the major cause of death from TBI is self-inflicted injury. As we continue into our golden years, now it's falls. I know this red bar is shorter than the blue, but notice this scale on the y-axis. So falls account for the lion's share of TBI-related deaths in the elderly. Falls are a serious concern. Don't skip your leg days. Now, as far as traumatic injury to the spinal cord goes, well, it's a lot less common than TBIs. Okay, so here we can see that 2013 estimate of a mere 890 per 100,000 per year. And that's bumped up, right? We've broken out of this plot nowadays, but spinal cord injuries, not even close, right? Less than 1%. And that's great. What's also changed, what also differs a bit, so in the age of injury, we see spinal cord injuries are happening a little bit later now than they used to in the past, so you can see your typical age there. When we have a spinal cord injury, most commonly what we see is some degree of incomplete quadriplegia. That is, we have weakness and sensory loss, but it's not complete, and it affects all 4 of the limbs. After that, we see either a mix of incomplete or complete paraplegia. Those are about as common, about 20% each. And then the least common and most severe would be complete quadriplegia. That is, we absolutely cannot move or feel our upper or lower limbs. Now, the causes of spinal cord injury are pretty much the same culprits as traumatic brain injuries, but there's a slight different mix. So motor vehicle accidents create the lion's share of spinal cord injuries. And yes, they contribute to TBIs, but the big thing for TBIs is violence, either from another person or from the self. So violence, you can see, is the tallest bar here for TBIs, but it contributes not quite as much to spinal cord injuries. Here, the big things are motor vehicle accidents and falls. Falls contribute about the same to spinal cord and brain injuries. And then we have, of course, the other category. These would be injuries playing sports or some medical, surgical complications, things of that nature. All right, risk factors for spinal cord injury is, again, being male. Ladies, it's not easy being us, all right? Cut us some slack. So you can see males are accounting for the majority of spinal cord injuries. And we see a disparity between the races. So if we look at the number of spinal cord injury in white and black Americans, sure, white Americans contribute a larger number of spinal cord injuries, but when we consider their population size, and calculate a rate over here, we can see that the risk of a spinal cord injury is about doubled for black Americans compared to white. When we have a traumatic injury, this is caused by some outside force. Now, that outside force can actually penetrate skull or spine, so it could be gunshot wound, stab wound. These would be open injuries. That is, we actually have something penetrating into nervous tissue. In the case of TBI, it penetrates the skull. In the case of a spinal cord injury, it penetrates the spine. A closed injury keeps the skull or spine intact, and what we're really doing there is just sloshing around the brain or spinal cord violently enough that we cause axons to get stretched enough that they rip apart, causing diffuse axonal injury. So these are the different primary injuries, right? Either we jerk the brain or spinal cord around, or something flies through here, physically causing necrosis of neurons. So the common outcome here during that primary injury is diffuse axonal injury. And that's caused by those rotational forces that are stretching axons. More commonly, we see closed injuries than open, so we'll consider those moving forward. Of course, open injuries will physically rip axons as well. All right, so here we can see some fancy MRI showing us axon projections. So here's our corpus callosum, and it's color-coded based on the direction the axon is running. The main thing we want to see here is that there's no like big gaps, until we get down here. This is following a traumatic brain injury. We can see axons are lost. All right, so really the site of injury is going to be the long elements. Axons, blood vessels. Those are the things that are going to be affected in primary injuries. When we injure an axon, we then see degeneration of that axon, and it degenerates in the anterograde direction. That's called Wallerian or anterograde degeneration. So what this looks like, let's say we have some traumatic injury, could be a bullet or a pair of scissors flying through the skull, or it could be enough rotational force to physically rip this axon apart. Either way, it's broken. Now remember, downstream of here, we can't produce any proteins. So while we may not have ripped this entire axon to shreds, it can't make its own proteins, and proteins do everything for us. So at the site of injury, we start to degenerate in the anterograde direction. And eventually we degenerate all of the axon. I have to do this. Okay, cool. So it goes in the anterograde direction. Now, hopefully this neuron is able to regrow its axon and reform synapses. That can occur in the peripheral nervous system, but not the central. So this neuron will no longer form synapses, so it won't receive any neurotrophic factors. Use it or lose it. If a neuron doesn't form synapses, we don't need it. So without neurotrophic factors, apoptosis. In the peripheral nervous system, things are a little bit different, but when we're talking traumatic brain or spinal cord injury, that's all central nervous system. Now, this is in contrast to what we see if there's some kind of problem with axonal transport. There, the degeneration goes in the retrograde direction. That is, we start degenerating out here, and then the more proximal segments eventually get lost. That's because we can still deliver proteins close, but we have trouble shipping them really far. So the distal portions of axons degenerate first there. That's not what we're dealing with in traumatic brain injury. It's all about this top anterograde degeneration. Okay, so we can have diffuse axonal injury. Right. The other thing we can do is affect our vasculature, right? And so this is fairly easy to visualize when we look at something like this, right? The hangman's fracture. So for spinal cord injuries, what's going to cause the majority of them is excessive flexion or extension of the neck, causing the vertebrae to hyperextend or flex, destabilize, and then shift. So here's our hangman's fraction over here. Notice we've got this shifting of the vertebrae forward. That's obviously going to start pushing on spinal cord or blood vessels, either damaging the cord itself because of that physical force acting on it, or disrupting blood flow and then causing ischemia, which then kills the nervous tissue. So whether it's direct compression of nervous tissue or the blood vessels, neurons are going to die. Here we can just kind of see how shifting would then compress a blood vessel. In that case, the upstream blood flow is going to be cut short, and those neurons will suffer ischemia. Okay, so after we have that primary damage to nervous tissue or blood vessels, then the secondary injuries occur. Now, part of what contributes to this is some kind of mass lesion, right? It could be, a giant, hematoma or something like that. This is clearly pushing on the brain. Notice we have this midline shift. So this should be in the middle, which is right over here. But we've displaced it. And anytime you see a midline shift, that tells us we have an increase in intracranial pressure. That can put pressure on neurons and blood vessels, doing the same thing we just saw in the primary injury. This could also be caused by inflammation. So we have a bunch of damage. Inflammation is there to clean it up, but hey, we got this pesky skull giving us a confined volume of the head. So any swelling that occurs increases intracranial pressure. All right. What that's going to do is alter blood flow. Remember, the cerebral perfusion pressure is the difference between our mean arterial pressure and the intracranial pressure. So if we have some kind of mass lesion or some swelling from inflammation, we increase intracranial pressure, which decreases the cerebral perfusion pressure. Now, the brain can compensate to some degree. There's some extracellular fluid here, so we're going to think of the brain as a pie. Most of it is brain tissue. We got some extracellular fluid. As we have this lesion or swelling because of inflammation, what we're going to push out is as much of that extracellular fluid as we can, but eventually we're going to reach a point where we're now impeding blood flow. It's going to be hard for us to bring in blood. And typically it's once we kind of cross this 20 or so millimeters of mercury. At this point, we need to do something. We need to either open up a hole in the skull, or we need to try to drain as much fluid as we can out of that brain. The problem here is if we decrease blood flow, ischemia causes ATP depletion. So neurons can't make as much ATP. When neurons can't make as much ATP, they don't fuel their pumps, and therefore they depolarize. Now, another way that we can get excitotoxicity is just the pressure directly stimulates neurons. Everything's mechanically gated to some degree. So when we put pressure on a neuron, we physically pull open ion channels. And another problem is anytime you have damage and inflammation, you get reactive gliosis. And those reactive astrocytes aren't picking up potassium or glutamate, and that causes neurons to depolarize. So whether it's the ischemia, the pressure, or the reactive gliosis, excitotoxicity is a major concern following a traumatic injury. Here we can see reactive gliosis that occurs following a traumatic brain injury. Now, this is in a mouse. That should be obvious based on the shape of the brain. What they're imaging here, the red is showing us reactive astrocytes, kind of. Okay, it's showing us just astrocytes in general. But this intermediate filament here, GFAP, it gets upregulated. And you can see they had an injury over here, and boy, that side of the brain is super duper red, indicating to us reactive astrocytosis. This is also true following spinal cord injury. So both TBIs and SCIs involve reactive gliosis. Now, that axonal injury is particularly devastating in the central nervous system because axons don't regrow. What they've done here is put some neurons down here in a dish, and there's a little silicone gasket here. So the only way they can grow their axons over here into these chambers is by growing through a nerve. The optic nerve, which is a part of the CNS, or the sciatic nerve, a part of the peripheral nervous system. So PNS over here, CNS over here. And what you'll notice is if we look over here in this chamber, that's what this image is. So there's the edge of my sciatic nerve. Some axons have grown out. Here we can see axon, 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 axon. Lots of axons making it through the sciatic nerve. However, if we look over here, what axons have grown out of the optic nerve? Well, here's the optic nerve and nary an axon in sight. So there's something about the optic nerve that differs from the sciatic nerve that prevents regrowth, and that has to do with the type of myelin that's there. So that's one issue. Oligodendrocyte myelin prevents regrowth. The whole idea is let's not rewire our brain. Once we've grown our axons and myelinated them, that's your general pattern. And we're going to have little shifts. But you don't want to wake up one day and not know how to walk and talk and all that jazz. So the central nervous system has very limited regrowth capabilities. The other thing that screws us up is the glial scar. So oligodendrocytes and astrocytes prevent the regrowth of axons. Schwann cells, on the other hand, which are in the peripheral nervous system, facilitate axon regrowth. And that's because the wiring diagram is much simpler in the peripheral nervous system. Go from this nerve root to this muscle or this patch of skin. It's A to B. We don't have complicated wiring diagrams like we do in the brain. So if we build up enough pressure, that can cause brain tissue to then herniate. So even though this is the area where we have our hematoma here, this big mass lesion, yeah, we're pushing on this part of the brain, but guess what? This part of the brain can push over on its neighbor. So we get this subfalcine herniation here where the cingulate gyrus crosses midline. This isn't great, but even worse are those herniation disorders where we see downward displacement, whether it's central herniation of the midbrain or this uncal herniation of the temporal lobes, or even worse, the tonsillar herniation of the cerebellum. When we push down on the brainstem and compress the medulla, we're at a risk of having respiratory distress, right? Because vital centers are controlled down here in the medulla. This thing is vital. Without the medulla, we don't breathe. So herniation can cause sites that are far away from the injury to be affected as well. And of course, with herniation, not only are we pushing on nervous tissue, we push on blood vessels. So ischemia is also a risk. Now, in traumatic brain injury, one of the things that can happen is coma. And coma can be caused by a couple of mechanisms. One possibility is that we have widespread cortical damage. Okay, so the cortex up here on top, the big wrinkly part, this is where the magic happens. This is where we perceive things going on. And so if you damage enough of the cortex, well, no more perceptions. That's a coma. More likely is we damage the ascending arousal system. And that's all this junk shown here. This arises from the midbrain and pons. It's also called the ascending reticular activating system. It's a system of axons that ascends from the reticular system to activate the cortex. So the name makes sense. Okay, this is what wakes us up. So when we're asleep, this stuff is quiet. That keeps the cortex quiet enough that we don't have conscious perceptions all throughout the night. We'll dream a little here and there, but for the most part, we don't hear things, see things, smell things. Okay, when we're awake, this ascending arousal system is back online, cortex is active, and we perceive stuff. In a in a traumatic brain injury, damage around the midbrain severs this ascending reticular activating system, giving us coma. Now, midbrain is the more likely site of injury because we've put all of our ascending axons in the same basket. I know this cartoon sends this over this way. That's for the cartoon. They all pass through the midbrain. So midbrain damage will have an increased risk of coma as a result. Now, if we have repeated traumatic injury, This can cause a condition called chronic traumatic encephalopathy. So we're going to have brain damage caused by chronic traumatic injury. And what this looks like is Alzheimer's disease. We see plaques. Check them out. We see tangles inside of neurons. So here's a tangle, there's another one, plaque over here and there. That's what it looks like in an Alzheimer's brain. But this is a 45-year-old NFL retiree. This is way earlier than we would expect to see this type of pathology. And it's caused by repeated injury. Likely what's going on is that those injuries are stimulating neurons. And anytime you stimulate a neuron, it spits out A beta. A beta is that peptide that forms plaques and then causes tau to misbehave and form the tangles. Okay, so repeated head injury bumps up A beta levels. And if we keep getting injured, we keep spitting out A beta, and that then gives us essentially early onset Alzheimer's. But we don't call it that. We call it chronic traumatic encephalopathy to denote that it's the chronic traumatic injury that's the cause here. Similar to Alzheimer's disease, a risk factor for chronic traumatic encephalopathy is the presence of the ApoE4 allele. And we'll talk more about this in our Alzheimer's lecture. But this is a protein that helps clear A beta. But the ApoE4 allele doesn't do it as well. So there are other versions of ApoE. There's ApoE2, 3, and they clear A beta better. But with ApoE4, we don't clear A beta. Couple that with chronic head injury, which increases A beta, which we don't clear, and you can see why this is a risk factor for chronic traumatic encephalopathy. The issue here, same thing as we'll talk about in Alzheimer's. If you make a bunch of A beta, that stimulates NMDA receptors, and you are at risk for glutamate toxicity. So we lose synapses, and then we lose neurons. Those tau tangles impair axonal transport, so we don't get proper neurotrophic support. We also don't have proper synaptic function. Use it or lose it. All right, and here I'm just going to try to summarize everything for our traumatic brain injury. What can happen? All righty, so there's our primary injuries. So those mechanical forces can stimulate neurons. It can just damage tissue, especially if it's a penetrating head wound, or it can cause diffuse axonal injury. Hey, if we damage our axons, no more neurotrophic support, boop, 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 apoptosis. That's pretty straightforward. Mechanical stimulation, okay, that can stimulate neurons, that can create seizures. It can also affect memory function because you've shaken up the hippocampus a little too much. When we stimulate neurons, they make A beta. Don't forget that chronic traumatic encephalopathy. Oh, that can then stimulate neurons, potentially exacerbating seizures and contributing to excitotoxicity. Alrighty, the mechanical stimulation itself might be enough just to get us directly there, so that's a nice simple line. Another problem is any tissue damage that occurs from the primary injury then leads to inflammation. Inflammation can lead to ischemia that contributes to excitotoxicity. That inflammation can also then cause herniation, which mechanically stimulates neurons or gives us some good old ischemia. So again, we're back to excitotoxicity. That tissue damage can lead to a hemorrhage. Hemorrhage, which then leads to apoptosis. We'll cover that in a bit. The big old hematoma can, of course, cause herniation and ischemia as well. So lots of possible ways of leading over to excitotoxicity, where in its extreme can cause necrosis through that osmotic necrosis or apoptosis because of oxidative stress. Now with spinal cord injuries, the problem here is that we damage axons within the spinal cord, which disconnects the brain from the motor neurons in the spinal cord and the sensory neurons in the spinal cord. So there's a few tracts that you need to know. The important ones are the corticospinal tracts. Here's the lateral corticospinal tract to control the limbs, anterior for the axial muscles. There are some other extrapyramidal tracts, but these aren't under conscious control, so no one knows about them, right? They still work, but no one's consciously aware of them. Not one of the major ones to know. The second major one to know is the posterior columns. These are columns of axons in the posterior aspect of the spinal cord. And this is just good old tactile sensation. You feel pressure, vibration, stuff like that. The third one to know is the spinal thalamic tract. This conveys pain and temperature, and this runs within the anterolateral system right here. Hannah will go through the importance of these in the next lecture, and I'll go through them in neurobiology next semester. Okay, but if we damage those tracts, now we're disconnecting neurons. All right, couple things can happen here. In the immediate, we get what we call spinal shock, and that is we see reduced tone and reflexes, and of course we lose control over our muscles, whether they be skeletal muscles or smooth muscles, doesn't matter. So spinal cord connects the upper motor neurons or some brainstem neuron down here to this spinal neuron, and that could be a lower motor neuron innervating some skeletal muscle, or an autonomic neuron innervating some smooth muscle or gland or something like that. Now, there's another source of input, and that's local. That's the sensory input. This helps create reflexes, whether it be a deep tendon reflex, also called a stretch reflex, or some kind of sympathetic reflex or parasympathetic reflex. Okay, now let's just consider that this spinal neuron has a certain degree of tone, has a certain degree of excitability. That's the action potentials over here. All right, let's get a spinal cord injury. And what we see then is we have now damage to our descending input from the brain. We have preserved sensory input, but we've lost a major source of excitability. So our neuron is less excitable. Okay, we move down that excitability, viability curve here. Uh-oh, I might not be excitable enough to get neurotrophic support. Use it or lose it. All right, well, what is a boy to do? Well, I can't listen to the descending input anymore because of the spinal cord injury. Hey, what if I listen to now my sensory input a bit more? This should say late phase. Didn't update that one. Okay, in the long term, what we see is spasticity. And this is true for skeletal muscle as well as smooth muscle. Okay, so I don't want to live down here on this low end of the excitability viability curve. I need to do something to increase my excitability. Descending inputs aren't an option. Ooh, but these are. And what we see is sprouting of sensory input into the spinal cord following spinal cord injury. This is just good old homeostasis here. So I've lost that descending input from the brain to tell me what to do when I need to do something. Now I'm listening more to sensory input, but keep this in mind. Sensory input is tonic. Our muscles always have length. Our smooth muscle is always stretched to some degree. So we're getting increased input all the time. So what we see then is increased tone from these lower motor neurons and autonomic neurons. Sure, we can't recruit them. We can't make them do what we want them to do, but we see elevated muscle tone and hyperreflexia. This is true both for the tendon reflexes as well as autonomic reflexes. So this is the basis for autonomic dysreflexia and the spastic bladder that we see in high spinal cord injuries. Now, strokes are another issue here that abruptly affect neurological function, and these are caused by either blocking or rupturing blood vessels. With ischemic stroke, we don't see anything too dramatic over here. Yeah, there's some damage, for sure, but it's harder to see than over here in the hemorrhagic stroke. Now, these tend to occur more deep like this because we tend to rupture our blood vessels at branch points. And so we'll tend to have then the deep vessels giving us hemorrhage here. And it's pretty obvious where we have the hemorrhage. All right, enough of that. So strokes, overall, we see about 150 per 100,000 per year, rough ballpark. 75% of those are first-time strokes, 25% are repeaters, and the majority are ischemic strokes. Now, there are plenty of risk factors for strokes. Some of them we can't do a darn thing about, like our age. Every year you're a year older, and it turns out as you get older, your risk of stroke increases. So here we can see as we get older on the x-axis, the likelihood of stroke on the y-axis increases. And the rough guesstimate is that after 55, every 10 years doubles your risk. The majority of strokes occur after the age of 65. So that is in accordance with age being a big risk factor. Now, sex is also a risk factor. Again, men have a greater risk of stroke. Now, women tend to live longer, so they're going to have more of that age risk factor. But if we take age into account, men have a slightly greater risk of stroke. Race is, again, a risk factor, but it's a little variable with age. There's some kind of an interaction effect, it looks like. So in the younger years, white men seem to have a lower chance than, Latino and black men. But then we get older, and that kind of flips here, right? So here we're looking at, you can see the sample here. So folks around kind of this area. So white men over here, black men over here. So blue and green is who we're comparing. Now in the younger years, we see a greater incidence of stroke in black men. That evens out once we get past 65, and then risk in white males takes over. So race is a risk factor, but it varies with age. Okay, other things we can't modify are genes. So there's a number of mutations, and no, I don't care if you know these genes, but what they do is modify how our smooth muscle forms. And so when you have these mutations in FOXC1 or PITX2, what we see is smooth muscle doesn't really line the blood vessels as well. So here's non-mutated, nice green blood vessel over here going all around it. This is what we'd want to see, a nice ring. Over here, ugh. So the smooth muscle is kind of aggregated and improperly formed. And, well, this blood vessel is going to have a hard time regulating its diameter, and it's not going to be quite as elastic. And that's clearly not a great thing. So it could be a problem with the blood vessel, right? A couple mutations affect smooth muscle. Okay, then we have mutations that affect blood cells, right? So sickle cell disease, for example. This causes the blood vessels to go from, the blood cells to go from nice round, pillowy blobs into these kind of sickle-shaped structures that are easier to kind of get caught up on each other and form clots. That, of course, increases the risk of then blocking a blood vessel. Then we get into the modifiable risk factors here, so something you could do something about. Okay, so we want to prevent atherosclerosis, right? So we don't want any kind of buildup in our blood vessels. That's going to be related to diet. Hypertension is also modifiable, so you can take medications or modify your exercise and stress levels, hopefully, to decrease blood pressure. And we can see here the risk of having elevated blood pressure and elevated stroke risk. So the higher your blood pressure, the higher your stroke risk. If you can lower your blood pressure, you lower the risk of stroke. So that's kind of nice. Cardiac disease is another issue here. So if the heart doesn't move the blood out, the blood can clot. And then when those clots leave the heart, they enter the brain and plug up some vessel. You've got yourself a stroke. So after we have a heart attack, stroke risk is elevated. We really need to make sure we thin out our blood. Yes, there is something you can do about that. AFib, so atrial fibrillation. This is also a big stroke risk because we're not properly clearing blood. So we'll have to take some blood thinners to make sure we're not forming clots, right? Because we're going to get like a hugely elevated stroke risk. Another systemic factor to worry about that affects the blood is leukemia. So in this case, if we have a whole bunch of white blood cells getting born, our blood thickens up and, well, it's easier then to block a blood vessel. Diabetes is another risk factor. While you can't get rid of your diabetes, you can certainly manage it. Maintaining a healthy diet and using insulin therapy as appropriate. Insulin is super important, not only for regulating blood sugar levels and keeping neurons alive, but it also regulates the size of our blood vessels. So here we can see the risk of stroke. They break it down, ischemic, hemorrhagic, and several different studies over here. This is just any old stroke. Having diabetes versus not. So any of these numbers that are greater than 1, and when you look, they're all either pretty much 1 or well above 1. So diabetes, whether it's type 1 or 2, increases the risk of stroke. We can see in this study, at least, ischemic stroke was higher than hemorrhagic, but across the board, we're seeing an increased risk of ischemic stroke here, which is the most common type of stroke. Here we can see what insulin is doing for us. So when we add higher doses of insulin, that's the x-axis here, we're looking at then vasodilation. So the further down we go, the more dilated we are. So add insulin, we should get vasodilation. That probably has something to do with diabetes as a risk factor. Diet definitely is a risk factor. This is definitely modifiable. So fatty diet. So here we have normal diet and then a high-fat diet. These are in rats. This holds true in people, though. So a normal diet, they are much more responsive to insulin. High-fat diet, not as responsive to insulin. Now, I will say the type of fat matters. So there's the bad cholesterol, low-density lipoprotein, or LDL. So the more of this you have, the more likely you are to have heart disease and stroke. So if we look over here, this is our non-HDL, so we'll call that LDL. As we increase on the x-axis, have a look here. No matter what we're adjusting for, I don't care. Look at either line as we move from left to right. The risk of heart disease and stroke increases. Of course, if you have heart disease, that increases your risk of stroke. Okay, over here, the HDLs, that's what we're looking at on the left. Notice as we increase the amount of HDL, we actually decrease the risk of stroke and heart disease. That is why we call it good cholesterol. The HDL doesn't seem to stick into our blood vessels like the LDLs do, and the LDLs get consumed by macrophages and stimulate inflammation in the blood vessels, leading to those atherosclerotic lesions. So here we've got the bad cholesterol, right? LDLs depositing in blood vessels, and then macrophages come in and they break them down and we get these plaques forming. So the LDLs are the ones that tend to stick in blood vessels and form the atherosclerotic lesions. Obesity certainly matters, definitely related to a high-fat diet, but not always. Now, if we look over here, obese folks, and these are humans, not rats, you can see their response to insulin is, on the average, lower than that of folks who are not obese. Now, certainly it's a complicated tale with obesity because there's a number of other risk factors that are a lot more common in obesity, but who cares about that? Which one is the cart, which is the horse, doesn't matter. If you have obesity, you're more likely to have diabetes and atherosclerosis, and therefore you are more likely to have stroke. All right, there's other things that we put into our body besides food that affect stroke risk. Smoking, you can see, increases stroke risk over here, right? Maybe the same for cannabis. We don't know enough about it, but with legalization, we'll see how those data shake out. But definitely inhaling smoke is not good for you. So avoid it. Alcohol has kind of a complicated tale here. This is moderation. That's what we need to think. Everything in moderation. That's the takeaway here. Okay, so a couple types of stroke. You can look at stroke risk in men versus women. Cohort case control is the study design. All right, if you care about those things. So if we look just overall stroke risk, this is the amount of alcohol intake. So if you're having, about a drink or less a day, that decreases your risk. And one or two drinks doesn't increase it. In fact, it decreases the risk of ischemic stroke, as we can see here. Once we get beyond that, especially when we get into the more than 5 drinks a day, 5 or more drinks, right? When we get into binge drinking, that increases the risk of stroke. Those low levels might be protective because they tend to increase HDL levels and thin out our blood a bit. So maybe that's why we have decreased ischemic stroke risk with a little bit of alcohol intake. And here I've just plotted it for you in case you like pictures instead of numbers. Fair enough. Cocaine, methamphetamine, these are vasoconstrictors, and so they can decrease blood flow, and therefore they increase stroke risk. There's a lot of other reasons not to use cocaine and methamphetamine, and I doubt this slide would convince you one way or the other. All right, so what's going on in stroke? Well, with ischemic stroke, the problem is we've got a loss of blood flow. So whether it's, some thrombic lesion where we're just kind of narrowing the blood vessel, or we have some hunk of junk, some embolus that blocks the blood vessel. When neurons don't get blood, their ATP levels drop, and now they can't fuel the pump. All right, couple of things are going to happen. In neurons, this directly depolarizes them, causing the release of glutamate, which, depolarizes them. Notice this right here, positive feedback loop. Those are never good to see. All right, so we spit out more glutamate. Hey, we can get glutamate toxicity, and that'll kill you in a couple of ways. If we get that old oncosis, that can trigger reactive gliosis, and we definitely see this in stroke. And then we're not picking up glutamate as much. But wait a second. How do we pick up that glutamate in the first place? That ain't free. This also costs ATP. So, because it relies on ion gradients. And hey, we've screwed up our ion gradients, not only in neurons, but in astrocytes. So, because we don't have the proper high sodium outside, high potassium inside, astrocytes aren't picking up glutamate as much. Oh no, we're back to the elevated glutamate levels and glutamate toxicity, and it's the same thing we've seen time and time again. Hemorrhagic stroke can still cause some downstream ischemia, so all that stuff is still true, but we got a couple of other problems. Now, where we tend to see hemorrhage are at branch points. And what these seem to probably start off as are aneurysms. These are little outpouchings of a blood vessel, so this represents a weak point. We commonly see aneurysms at branch points, and this is commonly where we see hemorrhage. So we think of aneurysms as kind of starting off, and then eventually they balloon up enough and they rupture. And you find aneurysms in a surprising number of people, right? Even without stroke. So these are probably like the baby step, and then we go from aneurysm to hemorrhage. Okay, now what's causing these aneurysms and hemorrhage is in part hypertension. Okay, so when we have elevated blood pressure, blood vessels are going to respond. And one of the things that they do is increase the amount of collagen that they lay down. So here we can see collagen stain in blood vessels. So a couple different layers to think about. Here's our opening, right? Collagen shown in red. Blue is just showing us where nuclei are. Not interesting. So we got some collagen. So the blood vessel's tough, but it's not stiff. Now, when we elevate blood pressure, so if we induce hypertension with a little angiotensin 2 here, now you can see tons of collagen laid down in these blood vessels, a big thick wall of it. This is homeostasis. So if we're constantly putting pressure on the blood vessel, it responds. And it responds by becoming tougher. This is great until it's not, right? When we put enough pressure rather than stretching, it ruptures. And there you've got yourself hemorrhage. Now, not only do we respond with collagen, the smooth muscle responds to pressure, and what it seems to do is differentiate into macrophages instead of smooth muscle. So we are less flexible because of the increase in collagen, and we're less elastic because we're losing smooth muscles. Oh, and those macrophages trigger an immune response. They trigger inflammation in these hypertensive blood vessels. And chronic inflammation leads to fibrinoid necrosis, that is, necrosis of the vasculature. This also occurs in cerebral amyloid angiopathy, so we'll get the cartoon of that in just a second. Okay, last thing to think about with hemorrhagic stroke. A beta, right? We saw that with traumatic brain injuries. We'll see it in Alzheimer's disease. Same peptide. It can also affect blood vessels. So it can stick in blood vessels and form plaques there as well. And that those A beta deposits decrease blood vessel diameter, so we got an ischemic stroke risk. Okay, that's not good. But what we're also doing is creating an inflammatory response. So it could be fats, it could be hypertension, and it could be cerebral amyloid angiopathy. Whatever it is, if we have inflammation in the blood vessels, we get that fibrinoid necrosis, and that increases our risk of hemorrhagic stroke. And here we can see a bunch of microhemorrhages accumulating. So this creates vascular dementia. Here's someone who had cerebral amyloid angiopathy. And when you take a look at their brain, there's a ton of holes. That's because their blood vessels became leaky. So they had microhemorrhage. So first option with cerebral amyloid angiopathy, we lay down so much A beta and we have inflammation that swells it and we just occlude the blood vessel. So we get ischemic stroke. Okay, the other thing that happens is we lay down our A beta, that's shown in red here, that triggers an inflammatory response. We get this fibrinoid necrosis occurring. We're breaking down the blood vessel, and that leads to the leakage of blood out of the blood vessel. So we get hemorrhage. All right, so for hemorrhagic stroke, what's going on here? So when blood leaks into the brain, it brings along with it hemoglobin, which is broken down into free heme. Okay, this does a couple of things. This causes oxidative stress, so it forms free radicals that then non-specifically damage DNA and lipids that can make our mitochondria leaky, and we get apoptosis. All right, so if it goes into a neuron, it can kill it by oxidative stress. Now, it can also get taken up into glia, triggering an inflammatory response and reactive gliosis. Okay, same stuff as before. With inflammation, we increase intracranial pressure, and that can directly stimulate to get excitotoxicity. It can also cause ischemia to give us excitotoxicity. Either way, our roads are ending in excitotoxicity. Now, another possible thing that increases intracranial pressure is that hematoma that forms. So when the blood comes out, it also occupies space. That mass lesion increases intracranial pressure that can stimulate neurons or compress blood vessels. Either way, it's excitotoxicity. Then finally, blood has stuff in it besides free heme. It also has a bunch of potassium and glutamate. So it has higher concentrations of potassium and glutamate, and those are the things that, stimulate neurons. And this is exacerbated by the inflammation and reactive gliosis, because now the astrocytes don't help clean up that potassium and glutamate as much, and oh, by golly, we've got excitotoxicity. Now, one last thing to cover. We don't always have full-blown strokes, right? Sometimes we have transient ischemic attacks. That is, we might have a brief occlusion of a blood vessel. Could be there's some hunk of junk that rapidly dissolves, or the blood vessel just has a little spasm, a little vasospasm occurs. And so we get a very brief disruption in blood flow and thus very transient neurological signs, right? These will just last a few minutes and then completely resolve. That doesn't mean that everything's fine. This is most definitely a warning sign, because if you'll look, after 3 months, 17% of folks have had a stroke following a transient ischemic attack. and 4 years later, a quarter of them are dead from a heart attack. So if you experience a transient ischemic attack, this is a clear sign that you need to go see your doctor and address those modifiable risk factors. Now, if anything in this lecture has been confusing, that's a clear sign that you need to fill out the questions box or come by my office so we can chat. But chat we must, and chat we will in class. I'll see you there.